Bring it out. Get it out, John. All right, John, get it out, Shannon. Up with it. Go ahead, Marcos. Go ahead, Marcos.
I don't think there is a 22.
Where is he now?
Too much, Tom, too much.
Bring that up, Bravo! Bring it up!
Go, Marco, go, Marco.
All right, Dave.
Go white!
All right, nice ball, man.
Good.
Joe told me to warm you up. He'll put you in there and rub you down a little bit. That's what he did. Last quarter, he runs you in there. Let it go. Hey, boy, Mark.
Come out, switch post!
Is this anything like a Rashad party? What are we doing here?
I don't know. I have no idea.
You think that's why he moved?
Yeah, right. He'll be interested. You want to send him a tape of this?
Jason ever get straightened out all the problems he had with the cops?
I told my cousin that story last night. It's hysterical. miracle.
Look at that ball. Look at
Ball.
that ball. Look at that ball.
Oh, yes?
Ooh.
Yes! All right. Right idea.
Yes. Other guys, 8 out of 10, they can't even kick it basically. That's the problem. All right, Mark. Come on, buddy. There he goes again. All right. Good boy, Marco. Nice ball again. Atta boy, Lama.
Tommy Mac, go! Come on, Louis.
That was a nice shot. You get that one?
Yep. It's a basic out.
No, I meant over there.
Yeah, that one I got. Yeah. Got them all. Big and small. Got them all.
Big and small.
Big and small. Okay, so without looking for his number,
Take the go pick.
without looking for his number, I don't know who he is.
Oh, man, this guy's got no hands here. Oh, man.
Helen! Helen!
That stupid blue player got right in the way. So I was going to take a shot.
That's right, I got him good. See, did I put a tape in here this morning? Parents don't allow you on the other side? So,
Yeah, they
kidding? Yeah, they do.
do. Well, there are times when they have,
Huh?
in my younger days,
Yeah.
they may not. They have buyers meeting. Is that funny the other day with Sam though?
Yeah.
Both times I was cracking up.
First.
Ooh, little action. You see that? Good like that. Take him. Ooh, no, man. Come on, ref. Oh, yes.
Beautiful ball, Bobby. Atta boy, Booker. Atta boy, Dave. Stay with us. Back a little bit, Ray.
Let's go, Hawks!
That calls everything.
Outside. Nice. Why don't you keep the ball down so you can do something with it? Up in the air with this wind. That's something over.
Whoa, good one, Joe.
I can't see. As what? Haven't said that yet. Just broke my leg. See that? A trip and I hit myself.
I mean, thank God you came over here. Otherwise, you would have followed 22 the whole game. We would have got it.
That's right. Would have sold the tape to his father. Who was that? 16 over there? Is that Dave? In the golf.
Yeah.
Thank God, I'm doing them all the time. Sound like a punk.
Playing against the wind.
Well, they'll get a chance to play with it. It'll switch later though. When they switch. Yeah.
Give it to him, Mike.
Yes! Yeah!
Whoa.
Ah.
Right idea.
Shame he couldn't get that ball quicker, huh? Wasn't it? He waited to open up the telegram. See?
Okay. No.
No
No?
offside.
Ah.
Offside.
Ah.
I used to call balls and strikes for center field. I found out I couldn't do it. Yes! Nice play, though.
It's all right. I got the Russ picture.
You don't get too many with them speed ball either. Give the ball wide.
Ooh.
Easy. Yes! We hook! Yeah! 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 That's what we're doing, referee! That's what goes in there. And a boy, Bob. That's the way Monmouth is. Man, that's the way it came in the man. Get another one. Two more, not one.
That's right.
Two more.
That's 2-0, guys. All right.
Yeah!
But it was only one in a row. Oh, he hit it right back to himself. What was wrong with that?
It was planned, huh?
Yeah, sure.
All right, John, put it home, baby. All right.
Come on. Playing with it, playing with it.
Come on, Mike.
Yo.
Whoa, mama. Oh, he's letting him play now.
I got tired of calling him.
There's 22.
How is 22?
Huh?
How is 22?
Oh, he's fine.
Right here. Is there a ball in play here? Anybody have a ball? No. Where?
Oh, here.
Oh.
Look at that ball.
Clear it! Yeah! Move out! Move out!
Yell at David.
That's the other team.
Oh, 22? Where's the ball? Where's the ball? I lost the ball. Aiming too close, I lost the ball. What was wrong with that? Finish your kitchen or what?
Yeah, they finished it.
Yeah?
Yeah. They, we still got a lot of paint and stuff.
Yeah, but they put it together and everything.
But everything is together.
Yeah. Oh, that's
nice.
Yeah, that's good. What did you do with the, what did they take the other stuff away
They
or?
took it away. Yeah.
Huh?
That was part of the deal.
Yeah. Another $1,000.
No, really, they treated us really good.
That's good.
I would recommend those people anybody.
Yeah.
They did a nice job.
As long as you can wait the year.
No, this is not the guy.
Oh, you got a different guy.
Yeah,
Oh,
we
that's
said the
right.
heck with the other guy. We finally went and got somebody else. Only took a matter of a month.
Jeez.
The other guy is, Arlene told him that we hired somebody else.
Yeah.
So we would, that's all right. We probably couldn't have got there till January anyway.
Oh.
You believe it?
Meantime, they got to run. So what are you counting on?
They got to run?
I was waiting for you to wake up.
Seen many of these games, have you?
I see these baseball games all the time. just haven't figured out where first, second, and third is yet. I can figure out where home is.
Again.
All right, John, real.
Hey, Scotty! Come in! Johnny! Turn up! Man on, John. No, no. Keep. Come on, Steve, get out here. Move it up. Up in the air, Mama. That's the best ball you can make out of that. Man, only got drift up. Come on, Mama, touch this goalkeeper, please. I don't care if it's a 50-foot shot. Come on, Steve. The ball! The ball, Hawk! Ball, Hawk?
Scared me.
Scared the hell out of me. I'll try to throw that hard ball, will you? I'll try to throw that hard ball, will you?
Win the ball. Jeez. Ball, Tommy.
Yes? Come on, Rick! Yeah! Yeah! Good goal!
Come on, John, take it from him. That a big. Looked like a good play to me.
get here? Or?
Yeah. All right, Dave, all yours. Traffic good. Go, go, go!
You remember Neil Blutig, don't you?
Is that Neil? Oh, Jesus. I was wondering if that was him or not. Yeah.
Give it down! Yeah, nice try! Ball! Come, back, turn out, turn out. Ball's not out.
They're all using most of them are farming as well as far as traction. It's a melting pot.
All come out from this alleyway with black sweatshirts on with hoods on. You know?
Medicine.
He's got the same team for him, man. Good.
What happened to 22?
22.
Did I lose him somewhere?
How's Arlene? Nervous?
She's looking for what do you call it? A program.
Last this year, chicken feet and Five is
Nah, doesn't play. He can't. He's got a. He started to play when he first joined high school. When he first went to high school. And because of these extra bones that I have on my body that he inherited, every time he runs, it like explodes on him.
So you can't play anything.
Nah.
He got big, huh, Joe?
Yeah. Sure did.
Come on, Dave.
Oh, this is
All right,
trouble.
Lama, give it to Marku.
What is, isn't that dangerous? Sit down.
come on, come on, come on, come on. That a boy.
Good boy, Mark.
Yeah, I love. Yeah, I like Stank.
All right, Michael, make a little run in there.
Big pull off guys. They don't miss anything. Consistency is not a virtue. Give him a nut, give him a yellow. Another one. Can't open. Yes, it did.
He didn't give me the defense. He told me to sit down.
Sit down.
He was taking the second pair of gloves off. I thought that was enough to yell at him.
Just trying to kill the
I had a ref tell David a three-hole tournament one day. Sit down, give him a card and everything. I didn't play it. So literally he threw me off the field.
That threw me off already. Guy said to me, I can ask you to leave. I said, you could. If you like to, you can. I don't know if I'll go.
This guy says to me, go to the tent. I said, wait a minute. They can tell me to leave the field. I can't tell me to go to the tent.
You want to get undressed? Get undressed in this thing.
Well, why not? That hot dogs and hamburgers there. Tell me you're hungry.
Yesterday, guy said, I can ask you to leave. And I said, I just made a comment that you're doing a really terrific job.
Come on, Dave.
Oop. Back to the back, nope.
It's John Russo. Stopper
Come on, Mac. Get out of it. Come on, Mac. Nice ball. Tommy Mac.
Tomorrow.
Tell you, thank God my parents are in Woodbridge.
Yeah, close.
balls.
Take it yourself, Marku.
Did you see that play Sunday? Monday that Sims? I thought he did that. No, Jeff Coach, I don't know. It just looked like he went there to break his leg. Now they're finished. They was.
Good fake, Dave.
They are quick. What?
Physical.
Yeah, very physical. If you don't call, the interpretation, like that. Push a guy off the ball. Did you push him more?
With shoulder touch.
Even when you have possession of it?
Yesterday, they call it that.
As long as you don't have your arm.
You can actually push a guy off with the shoulder? Even when you have possession? You can really come right off the ball? Really? I mean, anytime we have the ball, you can really push him right off.
Put your arms in.
Ooh.
Ooh.
That was a good save. That was going in. I didn't realize you can really push somebody off. I thought if a guy has the ball, you can try to get you're gonna move him right off the ball. But isn't it interpret if you play the ball or play the man or
You can shoulder touch.
yeah. I didn't know that.
You get it shoulder.
Really?
As long as your arms are in.
Yeah.
You can't go up like that.
Yeah. Beauty. Good. He really nailed it. Neil, soccer stadium's next door. That's where you play.
No, I've been there a long time.
Oh, you been? I didn't know if you've been.
I sat on the bench at that one when I was a freshman.
Yeah.
I sat on the final.
The who?
When I was a freshman, was the state final. It wasn't there. Come on, Mike. The game before that.
Come on, Michael.
I've never seen him call so much in my life.
What?
Never seen him call so much in my life.
You going to ShopRite dinner today?
No, didn't we? You?
I'm going to the hospital.
Oh, is there a hospital there too? Where is that at?
Out by Shea Stadium.
Oh, I never went. I didn't even know Shepherd had a dinner.
Oh, they got a big dinner today.
You know, it's a big one tonight?
James Way's got a big one tonight.
Thank God I didn't get caught today anyway. I didn't catch me.
Sure. You threw him out. Don't tell me you catch.
No, they didn't catch me on that. Uh-oh. I'm going to Scarborough Fair tonight. You go down there?
Yeah, so?
Down on the ship, Belmont, down right down near the circle, near the, you know what they call it, the flea market is indoors?
Yeah.
It's right over there. Henry's supposed to have a party today. He canceled to next week because he needs you here.
Yeah. Right.
Alan. know, you too. Yeah.
More times than not.
You know, last, you want to hear funny? Did you ever watch this moron on TV, Morton Downey Jr.? I find him offensive. Me too. Oh, Speed's there, it is, babe.
It's in.
That went in?
Looks in to me. Oh, it didn't. It did. Yeah.
Downey's making mincemeat out of him. I said, why take that abuse? He should have told him to stick it.
That's right.
And he's that about Audi's car, you know, about the, it must be that.
I saw it one night when I was flipping channels.
Oh, I didn't see that one.
X-rated.
Yeah.
So bad. She got up and left.
Good for her.
Got up and left.
Good for her.
And he said, listen to this.
Boy, Mark,
He
come
said,
on.
I don't know why a woman, this ethnicity, who would let people put things in every cavity in her body that she has would walk off the stage because I said so.
Arrogant. God, someone's gonna pop him, boy. Where'd he come from? I don't know, but let's say New York. I heard he was on the radio. They had the, what do you call it? The KKK on there later.
Yeah.
Did you see how he abused these guys? They had every right to get up.
I saw.
What, did you take the sheets from them?
No, they were all in sheets.
Yes.
Really?
Oh, the whole front
No
row.
kidding.
Yeah, I turned it off. I didn't see him walk off.
No, they didn't walk off. They should have. He threw
Come on,
a guy. He threw guys
Come on,
off
Dave,
last
take
week.
this guy.
Ooh. Yeah. He'll get better. Boy, he's
Peace.
Go ahead, Lama.
See, they really open this field up.
Come on, Tommy Mac.
Nice thought, nice thought.
Good try, good try. Good idea. All right. Real good idea. Nice playing, Archie.
Sorry, Mac.
So if John wants to know what David's doing with his own body.
Give it to us, Bill.
No.
You want it?
No.
Good. Oh, good one. Cross.
That means that David's got my old body.
I don't think we ever had a body like that, Joe. I don't think of that, Joe. Really move that ball around well. Is the goalie the senior? The original? Really? The other kid? Campus. I've never been here before. Journeyman? Your boy also senior, Joe?
Yep. College bound, my honey.
Where's he going, Joe?
I don't know yet. Wants to go to California.
He had the lead in the play last year as a junior.
Never going to the theater.
Yeah, that's what he likes.
That's what he wants to do.
Good.
I told him learn how to drive a cab and wait on tables also.
Exactly right, Joe. You happen to hit it.
Now he's going to go to college first off for communication and stuff, so that he's got a degree in something.
Except it's very expensive to get showing back and
Did
forth.
you see,
Yeah.
see in the paper today, the Asbury Park today's paper, some guy, some real estate, some travel agency
I saw that.
was selling
$29.
$29 to Hawaii, right? Now,
Yeah.
Joe,
Yeah, listen.
here's the kicker. You get there,
What is it?
the rooms are $1,600 a week.
Is that for real?
Yeah.
I didn't read that. Oh, you go to interest. Why? Well,
what they said.
Morons. Image doesn't make business for you.
They're the worst.
Oh, yeah.
They are the worst. I mean, you try to find out where a shipment is from them. Oh, man, all they do is sell.
You know, because my partner called me this week, Larry, you know Larry. Said to me, came back from, they were at a meeting and he said to me, talk out and say, listen, I'm getting calls that you and I are splitting up.
Did you ever read?
Do I know something that you don't know? So I said, not as far as I know. I said, I want you to stay with me as long as you're Wendy. That's forever. He says, I just got a call from Bradley. He said, you guys are splitting up. I said, Jesus, I didn't think we were that important. Anybody even talk about us. I said, I don't even know who would even start that. Are these most of these kids Jersey kids?
It's only one kid that's not 16.
What is he, he came on his You played rugby, didn't you? They that good? Good.
I mean, it's nice.
Did you? What was it? Go win or lose?
Well, we lost, of course.
Did or?
We won. They won. They scored 3 goals in the first half.
And then you stop.
In the second half, we won. We outplayed them.
That's it. What do you find?
Oil, automotive, lipo, batteries,
You find my
candy
you buy candy also?
for the drugstore.
Yeah, Mike, wait.
Cross. Ooh. Only thing you buy from me is a shovel, right?
Yeah.
Oh! God, be close. Hold up, yeah. Gonna be a good shovel, you I think, Joe.
It's out.
Clem's still there, isn't he?
Yeah. It's on drugs now.
He's on drug.
He's buying the pharmaceuticals.
He's a nice guy.
Yeah.
He's good to me, I think. Beautiful. Is that in?
No.
Good serve.
The sound is automatic, right?
Yeah. Well, I can disconnect it. I'm gonna watch a soundless game.
Yeah, you're right. Pretty sensitive.
Yeah. This one is. No, this one's fair. My old one is more sensitive than this one.
So you're doing a lot of work now, huh?
Yeah. There it is. You get your name known in a particular area.
Yeah, that's it.
Marlboro. Lots of Sweet 16s there.
Really?
What
There
am I
it
doing there?
is, Mike.
What do you charge? Like $300
I pay him.
But he comes with you?
Yeah, but if he's not working, or he doesn't have a Sweet 16 or a party, not a Sweet 16, but a party himself.
So, we used, you know who we used? The guy from Elizabeth.
Elizabeth.
Rod
Yeah.
too.
Yeah.
John something.
I don't know the name. What charge?
When we had it, $350.
It's not bad. Wasn't bad at all.
He would have first. We gave him so much work, Joe. He sends, he
Yeah.
sends us at Christmas time. He sends us, what do they call it? Fruit basket.
Really?
Now even.
Really?
You believe
Huh?
it? Fruit basket. Every time we see him at the fair, comes over to us like we're family.
It happens, I'll tell you.
He's
It
a very
really
nice
does.
guy. Oh boy, not a good pick. Bingo. Oh, goal! Good shot, huh? He didn't go up at all.
Never got his arm. That's the natural reflexes for a goalie, whether you miss it by 20 feet or
Well, he
not.
should have
You
gone
got him
up.
right?
Yeah, he should have went right
You know,
over his head.
that's all you got to do.
Oh, absolutely.
See him up in Lehigh to put him in for the first game. He didn't even move for a week. Never moved.
Well, he has to give him a little.
Well, no, you don't have it. You
never raised his hand. Never went up there, never left the side. I think he thought he was going to go over the net.
Yeah, he can get them back. Where the coach tells him sometimes.
Hey, bingo.
Oh.
Rick Monmouth guy. Him and his wife are down once. And she says, when is David wearing that black armband? Is he in mourning for the season?
Yeah, what is it? I didn't
It's
know
because
that.
the captain.
Captain.
I thought to myself, what a great idea. If you have a bad season, you wear.
I never knew that. Neil, did you know that? What?
I would hope so.
Armband David was wearing? Did you know that?
Know it?
You don't know? Neil was captain. Hey.
Oh.
Good one. Good work.
Oh, I didn't know that yesterday.
We sent Joel out yesterday for Chinese food. At 11:30, he's getting ready to go eat.
Come on. It wasn't David, but he was clean.
Yeah, I guess some kitchen.
That's a good jump for strong player. Ooh.
The hell's the ball? I'm going to anymore.
Oh, cute, aren't they?
Yeah. Well, one was babysitting. One was there. Had a male stripper. That was, it's the 40th birthday party for my friend, for Karen's friend. Yeah, it wasn't bad at all. And I couldn't imagine why I was the only one in the room after about 5 minutes.
Everybody lost their appetite. There was no food that night.
There was a lot.
Beat him! Got it.
Oh. I don't understand why her people standing by the bathroom throwing up. I mean, just,
Yeah, I
I
wouldn't
don't
know.
understand it.
Marchetti.
Oh, yes, oh, yes.
All right, nice.
Good one. Come on, catch up with it. It's still live. ball go out? No, the ball went out.
Ball went out.
There's an obstruction? Yeah. Nice pushing in there, boy. What was it?
Yep.
Nice ball, man.
Right, don't they look like
Definitely that elbow.
which one? Slack. Big, isn't he? It's like a ball boy. Yeah, they could see 15 cost $95,000 to a play. That's not a big jet. Nailed it. Oh, it's a corner. Get it out.
So, did you find the college okay?
Huh?
You find the college okay?
Yeah, 22 was hard to find. Yeah.
Come on, Joe.
Me, Dave.
That's it, guy.
Phil, how are you?
Also, when you put something
cameras at us.
$1 a picture now. Jeez, you have to win a game? Where's that WFC?
You would have won more, right, Rob?
One more, we would watch magazine.
Inhibitors block the breakdown. A similar pattern is observed for the other neurotransmitters such as serotonin and dopamine that may be involved. The way in which the tricyclic and antidepressants and monoamine oxidase inhibitors work is by increasing the neurotransmitter in the synapse. This produces changes both in the intrasynaptic area and at the receptors, and the interaction between the enhanced amount of neurotransmitter in the synapse and the changes in the receptors parallels the changes in the clinical state and appears to explain the antidepressant effect.
There's been a lot of interest recently, and this is where much of the debate arises, that it's not in fact the level at all that is the precipitating factor for developing a depression, but it's actually a down-regulation of the neuroreceptor in the synapse.
Lithium works by a somewhat different mechanism of action. It is used primarily in bipolar or manic depressive illness and also for recurrent depression. It does not increase or alter the amount of neurotransmitter in the synapse, but appears to work directly at some component of the postsynaptic receptor site. It is also believed that drugs which do not work on these major neurotransmitter systems, at least in any way that we can understand, also may have antidepressant effects, such as some classes of benzodiazepines. This may be true for the subpopulation of less severely depressed people, because the way in which we characterize and understand depression is across a very wide spectrum. But the evidence that benzodiazepines work well, classic benzodiazepines that is, in true biologic recurrent endogenous depression is not that good at this time. There have been attempts to identify which patients are most likely to respond to one type of drug versus another. The first attempt was to use a substance called MHPG in the urine, but this has not proved to be of great clinical utility, and in fact is now primarily a research tool. The other approach has been to use something called the DST test, which is also used in diagnosis, and to predict treatment. The idea in using neuroendocrine tests, such as the DST in psychiatry, comes from the observation that the ability to suppress the output of cortisol by a substance called dexamethasone is lost in depression. This seems to be related to activation of the hypothalamic pituitary adrenal axis and an increase in ACTH, such that when you give dexamethasone, you do not suppress the ACTH and cortisol appropriately.
The test has been debated a lot because it's been used extensively, and I think initially clinicians took off thinking this was a diagnostic test for depression. It never has been a diagnostic test of depression. It never was meant to be that. It is an aid to diagnosis. So it's one more piece of data that a clinician can use to help make a treatment decision.
One of the problems in the current treatment of depression is the move towards newer compounds which may have fewer side effects, but which may not be as effective. Thus, we have the situation where people are treated with drugs for very serious depression, which may not be effective in the physician's attempt to avoid side effects. I believe this is a serious mistake and probably should be attended to by people sticking to the well-known established drugs for seriously depressed patients.
When we come back, we'll look at practical guidelines for drug therapy, as well as indications for referral to other specialists. Stay with us.
Lifetime Medical Television brings you Family Medicine Update. Informed, in-depth, up to the minute, with Dr. Robert Rakel hosting expert discussion, clinical reports.
We use colposcopy to check for tissue conformation, followed by a biopsy.
Advice about building a practice.
The communication you have with the patient is just as important as performing a procedure.
Family Medicine Update, Sundays 7 and 10:30 p.m. Eastern and Pacific. New
Voltaren, diclofenac sodium from Ciba-Geigy, world's #1 anti-arthritic, more frequently prescribed than any other non-steroidal anti-inflammatory drug. Voltaren, with 14 years of clinical experience. Voltaren is highly effective in the treatment of rheumatoid arthritis and in osteoarthritis, with an unsurpassed record of safety in tens of millions of patients. The world's #1 prescribed anti-arthritic is now available in the United States. New Voltaren, diclofenac sodium, world-proven effective, world-tested safe, world-chosen #1.
Physicians Travel and Meeting Guide, where physicians mix business and pleasure. Your guide to thousands of meetings cross-indexed by destination and specialty. Physicians Travel and Meeting Guide.
This 41-year-old man has really been quite a difficult problem for us. He's got a family history of hypertension and early cardiovascular complications.
Managing hypertension in daily practice, a challenge even with the most modern therapeutic approaches. Experts deal with concerns and misconceptions about hypertension therapy in a special 30-minute program. Hypertension Focus on Therapy. Coming next month.
Welcome back. Therapy for patients with depression can range from lifestyle changes and short-term psychotherapy to intensive psychotherapy and medication. For a discussion on antidepressant drug therapy, let's go back to our studio guest and specialty host, Dr. Robert Rakel.
Brian, I've really been underimpressed with any test that can help us make the diagnosis, especially the DST or serum norepinephrine or serum serotonin, what have you. Do you agree with that, and what is your preference for therapy?
I do agree with that. I've been underwhelmed with the usefulness of the DST and the other tests, and that's a disappointment, because when they first came out, we were really hopeful that we'd have something specific, some lab value that we could get instantly and confirm the diagnosis.
Oh, we'd love to have a lab test that makes that diagnosis. But if we know therapy is necessary, and I've been very impressed with the usefulness of drugs in the treatment of depression, how do you select the drug that you use in each patient?
I encourage the primary care doctor to be familiar in really great detail with a couple of the drugs.
Guidelines for using tricyclic antidepressants include recognition that 70 to 80% of appropriately selected patients will respond, and clinical effects usually require 10 days to 4 weeks to become evident. The 4 major side effects are sedation, postural hypotension, anticholinergic effects, and less commonly, cardiac conduction disturbances. Drugs with a high sedative activity may be beneficial in the depressed patient who is agitated, anxious, and suffering from insomnia. Drugs with less sedative activity might be more appropriate in patients with psychomotor retardation or hypersomnia. Patients with a pretreatment postural decrease in systolic blood pressure of more than 15 millimeters of mercury should be warned about avoiding rapid changes in position.
Isn't it true that no one drug has been proven to be any more effective in treating depression than another, or do you think there is a difference?
No, I agree about that. It's a matter of choosing among side effect profiles, and different patients will have different needs, and often you'll have to switch gears and switch medications. But that's a big point to make about working with these patients and these drugs, is to let them know in advance that these are not what I call user-friendly drugs. I don't find people who are eager to stay on them, and they're only too glad to get off them. But I think a lot of work can get done educating patients about that point, what the side effects are going to be, and then you can predict them, and then when the patient has them, you can say, well, now, see, we talked about that, and that's a sign that at least it's in your system and beginning to work.
Brian, what side effects do you normally alert the person to that are most common?
The one most people complain about instantly is dry mouth. That can be very bothersome, but often, like many of the other side effects, will ease up over time. Very often people feel somewhat drowsy or groggy, particularly in the morning. Constipation is very frequently a problem, and there are a number of other side effects that I find affect people less often.
And given the average tricyclic antidepressant, what dosage do you normally start at, and how high do you go before you switch to a different one?
I start with about 25 milligrams of your usual tricyclic, and I may do that as a test dose to see how well the patient tolerates it.
Especially in an elderly person, you start low, right?
Absolutely, absolutely. Start low, go slow with the psychotropics, just like with everything else. But you're particularly concerned about postural hypotension, so you want that test dose to see how they do. Once they clearly tolerate it, then I'll increase the dose by about 25 milligrams every other day to a dosage range of about 150 milligrams a day. If they tolerate that well, I'll go to 200. Now, most primary care doctors are uncomfortable about prescribing these drugs in those dosages, but that's what the therapeutic dosages are, and the commonest problem, as you mentioned, is that people don't give enough of these drugs for long enough.
And so we shouldn't give up until we've given it a good try, but it is also true that 20% of the time a drug may not work, and we do need to switch to another one.
There's no question about that.
If we do switch, any recommendation on how to switch or what to try second?
Sometimes people like using another tricyclic or trying one of the newer drugs that isn't one of the classical tricyclics.
If a patient fails to respond to the initial tricyclic medication, approaches to further drug therapy include a trial with another tricyclic or tetracyclic, a trial with a monoamine oxidase inhibitor, or selection of a drug from one of the other classes.
But if we have a patient that is not responding to drugs, that would be one reasonable case to refer to a psychiatrist. Would you identify other cases that we should consider referring early?
The other indications for referral are the patient who's suicidal, the patient who's psychotically depressed with delusions of worthlessness, for example, and those patients who really want to see a psychiatrist.
Great. Brian, thank you very much for being with us today.
My pleasure.
Robin, back to you.
Thank you, doctors. That's it for today's program. Thank you for watching. I'm Robin Groth. Please join us again for Family Medicine Update.
The pulmonary artery flotation catheter, its clinical applications and the controversies. Watch Physician's Journal Update tonight at 8 p.m. Eastern and Pacific on Lifetime Medical Television. New cardiac imaging techniques and how they compare with currently available methods. Watch Cardiology Update tonight at 9 p.m. Eastern and Pacific on Lifetime Medical Television.
Act 2 Haircutters, New York and New Jersey's #1 hair designers, want to give you something very special. Your best haircut ever. A dynamic, easy care cut or body wave that's always in fashion. Be it punk, progressive, whatever, you'll always look impressive, and it won't cost you a fortune. And Act 2 can even light up your life with super stylish highlighting. Act 2 Haircutters feature the Matrix line of fine hair products, including Vavoom, the new volume generators, shampooing, conditioning, glazing, forming gel, and freezing spray. The Vavoom way to say farewell to flat and dull hair. For that final touch, Act 2 has a professional nail clinic, electrolysis and facial salon, and even a silver solarium tanning salon for a safe, natural tan. Act 2 Haircutters at 21 Broad Street in Red Bank, 747-7770, plus 22 other convenient locations throughout New York and New Jersey.
For prescribing information, call 1-800-832-1199. Consult your PDR or tune into Lifetime Medical Television Monday through Saturday.
Milestones in Medicine is produced by American Medical Video, which is solely responsible for its content. Milestones in Medicine is funded through a grant provided by Park Davis.
Milestones in Medicine is presented by the Methodist Hospital Foundation, Houston, Texas.
Welcome back to the second part of the Milestones in Medicine program on modern diagnostic imaging. Our guest is Dr. David J. Skorton of the University of Iowa. Dr. Skorton heads the Division of General Internal Medicine and is Associate Professor of Medicine and Electrical and Computer Engineering. In our first program, Dr. Skorton and Friedewald provided us with an overview of current medical imaging techniques and discussed their capabilities as diagnostic tools. Today, our discussion focuses on the specific applications of these imaging procedures for evaluating disorders of the brain. We'll join Drs. Friedewald and Skorton after this brief message. Milestones in Medicine is recognized as a significant resource for the practicing physician. We're grateful to the millions of healthcare professionals and interested laymen who've contributed directly or indirectly to the success of this program. This fall, we have several exciting series planned, including an in-depth study of cardiac pacing, breakthroughs in the treatment and control of seizure disorders, a comprehensive look at the field of organ and tissue transplantation, and a special series exploring the quinolone class of anti-infective drugs. The Milestones in Medicine Advisory Board endeavors to choose topics that have been addressed in peer-reviewed journals and that truly reflect milestone breakthroughs having significant impact on healthcare in this country. If you wish to offer comments or topic suggestions, write to Milestones in Medicine Program Suggestions, American Medical Video, Post Office Box 66588, Houston, Texas 77266.
What are the major goals of brain imaging?
Well, in answering that, let me first say that this is my view of these goals as a clinician. I think there's a couple ways you can look at the goals of the specific organ system imaging we're going to be discussing. One is the goals as the radiologist sees them, and one is the goal that the clinician has in trying to answer a diagnostic question. From my point of view, the important goals of brain imaging are, first of all, to identify the normal anatomy, and is that anatomy changed? For example, are the ventricles of the brain enlarged or the sulci enlarged because of atrophy of the gray matter? Is there a space-occupying lesion that's distorting the anatomy? So the first goal is, once again, as we discussed, the identification of structure, both the shape and contour of the organ and the intraparenchymal structure. Next goal would be to have some evaluation of function of the brain. Now that's an elusive one. We in general have stuck to structural imaging for the brain, but it would be ideal, of course, if we could evaluate brain function. Now we're used to doing that in non-imaging ways, chiefly by our physical examination, neurological examination, also by some electrophysiological measures, evoked potentials, electroencephalographic recordings. Now, it's possible that we could get some evidence of brain function from certain imaging techniques, as we'll discuss. We'd like to be able to evaluate blood flow in the brain, especially, of course, in cerebrovascular disorders, but in some other conditions as well. And finally, we'd like to bring to the clinician, if it was possible, some estimate of regional and global brain metabolism and biochemistry.
Now, we have a lot of techniques that are certainly possible. Can you tell us which are the best techniques for evaluating the brain?
Okay, that's a difficult and a very important question. I'd like to try to answer that in two different ways. First, as a general overview, and once again I want to emphasize from a clinician's point of view, virtually all the techniques we've discussed previously have been applied to imaging of the central nervous system, starting with plain film radiography. Secondly, of course, angiographic imaging for angiography of the intracerebral vessels. Ultrasound has been utilized in the pediatric age group when there is incomplete ossification of the skull, and has been used in the operating room to identify the appropriate place for biopsies, needle biopsies in the brain. Ultrasound in general, though, except for that, of course, plays much less of a role in central nervous system imaging because of the very strong reflection at the skull interface of ultrasound, allowing very little energy to actually get into the central nervous system. Radionuclide techniques used to play a tremendous role in imaging the brain. The radionuclide brain scan was one of the methods of imaging the brain that a lot of us learned in past years. That's played less of a role recently and now is used much less because of the advent of more precise anatomical techniques. Now, one thing that's important to realize is that CT scanning gives us excellent anatomical detail for the central nervous system. Doesn't give us, of course, the functional information that some types of radionuclide imaging could give. And I think it's fair to hazard a guess that we'll be seeing a resurgence in interest in some forms of radionuclide imaging of the brain, at least potentially, along a couple of lines of inquiry. One is the possibility of evaluating a regional or global cerebral blood flow. There are some centers that are using, for example, a xenon technique, inhaling radioactive xenon, and then using the kinetics of xenon wash-in and wash-out from the brain substance to study regional blood flow. That's being done largely through a form of single photon emission computed tomography, tomographic brain imaging for blood flow. Positron emission tomography, once again, positron computed tomography, that is computed tomography using positron emitting radioisotopes, are showing the promise of very precise delineation of blood flow and delineation of metabolic events in the brain, such as substrate utilization, for example, glucose uptake in different portions of the brain using an analog of glucose such as fluorine 18 labeled deoxyglucose, or FDG, fluorine deoxyglucose, fluorodeoxyglucose. Finally, magnetic resonance imaging is finding increasing use. We might talk for just a moment about the comparison between magnetic resonance imaging and X-ray computed tomography. Both of these techniques will give you an anatomical presentation that to the clinician looks pretty similar. A transverse slice through the skull in which you see the skull, cerebrospinal fluid, the brain substance, gray matter and white matter. There are some relative strengths and drawbacks of the two techniques from a clinician's point of view. CAT scanning, of course, we have a lot of experience with, and it's much more widely available so far than magnetic resonance imaging, and has become, I think it's fair to say, the procedure of choice for evaluating central nervous system anatomy. There are some problems with CAT scanning. As you know, you get a very bright signal from any calcified structure, so when you're evaluating the infratentorial structures, posterior fossa structures, where there's a lot of bone around the substance you're looking at, you may have a hard time getting all the specific anatomical details you'd like. Now, magnetic resonance imaging has an advantage in that you don't get a very strong signal from compact bone, from calcified bone. Now, that's a drawback because you don't see calcification real well on a magnetic resonance image, but it does permit you to do a better job of visualizing the posterior fossa structures. And in my experience, early experience in using these two techniques in neurological imaging, I found that magnetic resonance imaging is very helpful in the posterior fossa and also gives you the ability to do these unusual oriented images different from what we're used to. So, for example, a sagittal cut will allow you to look at the midline structures, the falx and midline structures of the cerebellum and posterior fossa, and areas of the foramen magnum and upper spinal cord in a way that we were just not used to being able to do with CAT scanning or any other technique. So these techniques give you a lot of complementary information with some important differences.
Now, given this array of techniques, and we have a patient who will come in, we still have to decide which one of these techniques we're going to choose in a given patient. Are there any general guidelines?
I think the most important overall guideline that I might suggest to our colleagues out there who are looking at this from the clinician's point of view, the person encountering the patient for the first time, is to realize that we now have almost a bewildering array of choices to evaluate any given patient. Now, there's some good news and bad news about those choices. The good news, of course, is that we have a tremendous diagnostic range for evaluating structure and function of the central nervous system. The flip side of that coin, of course, is that wanting to limit the number of procedures we put our patients through from the safety point of view, wanting to get rapidly to the most efficacious procedure, and of course in an atmosphere of cost containment, we just don't want to throw every one of these imaging techniques at a patient. So I want to put a pitch in for a concept of utilizing a relationship with the radiological colleagues, not just as technologists to do an examination for us, but as consultative physicians. For example, a patient who has a headache. We'll talk about later a patient with abdominal pain, a patient with jaundice. I think we'll want to evaluate in a given institution what the best way to work that patient up is with radiological consultation. I think that's important for two reasons. One is undeniably a radiologist is the expert, the last word on these techniques and their strengths and weaknesses. And secondly, very importantly, just as each of us varies in his or her abilities and strengths in different areas, every institution varies in its particular expertise in the different imaging technologies. So, for example, your institution may have a longer history of utilizing a particular imaging technique. Mine may be weak in that area but strong in another area. So we'll want to know what the local experience is with each of these techniques. And of course, as we're aware, some of these techniques are extremely dependent on operator skill and ability to perform the examination. Now, of course, interpretation of these images always requires an expert eye, but in just gathering the primary diagnostic data, the ability to do that will certainly vary from institution to institution and from geographical area to geographical area.
The question of the experience of the laboratory, I'd like to spend a little bit more time on that, because my experience, at least in the echocardiography laboratory, is that really it takes 6 months to a year in a high-volume laboratory to become truly expert in interpreting those tests. Do the radiologists face a similar learning curve with these other techniques?
Okay. Now, of course, not being a radiologist, I wouldn't want to answer for that part of the profession, but I could try to answer from the point of view of someone who works shoulder to shoulder, so to speak, with radiologists in interpreting some of these examinations. I myself have had to go through a very prolonged learning curve in certain aspects of interpreting examinations that present anatomical information in orientations and visual perspectives that we're not used to. And I think an example of that you brought up, an excellent example, is the time it takes to learn to do an echocardiogram and to interpret it. Now, part of that, of course, is learning the vagaries of using the technique, holding the transducer, angulation, and so on. Part of that, I think you'll agree, is in recognizing the anatomical structures and the different ways that they can be presented. So it's the feedback between handling the instrument and seeing the anatomical information. Now, there are radiological techniques, that is, techniques that are done primarily by radiologists that also fit that very same kind of a scenario, same paradigm. For example, magnetic resonance imaging allows us a very broad latitude of imaging strategies, so-called pulse sequences, ways in which those magnetic moments of selected nuclei, usually the hydrogen nucleus or proton, can produce an image. Different pulse sequences will produce brain image, for example, in which we could make the cerebrospinal fluid appear bright or appear dim. Now, in a given situation, you'll need to have the radiologist's expertise at deciding what is the most likely cerebral pathology and what is the most likely way to make an image to get at that cerebral pathology. So even though it's not as operator dependent perhaps as ultrasound, it still is very dependent on the skill and strategy of the radiologist, and that learning curve has to be gone through. So I think a simple answer is that there is a learning curve that has three parts to it. A learning curve for identifying structures in new anatomical perspectives, a learning curve for knowing the comparative strengths and weaknesses of a technique in general in the field and in specific in your own institution, and a learning curve for each of the individual techniques, perhaps markedly so in ultrasound and magnetic resonance imaging.
Well, let's take now some classes of problems we might be facing. Let's start with space-occupying lesions of the brain.
Okay. Now, I think that one situation, of course, in which the clinician will think about space-occupying lesions of the brain is in neoplastic disease, benign or malignant brain tumors, either primary or metastatic. And in years past, we would evaluate brain tumors by history and physical, which I want to stress again is still the bulwark, cornerstone of this diagnostic evaluation. Then perhaps skull radiography and radionuclide examinations. And in selected cases, angiography before decisions made about a surgical approach. Now, that's changed a lot, and right now, I think it's fair to say that, in general, the skull film and radionuclide brain scan have been replaced pretty much by the use of computed tomography, X-ray computed tomography. If a clinician had to have just one instrument in the hospital to evaluate patients with central nervous system disorders, I think it would certainly have to be an X-ray computed tomogram, fourth-generation CAT scanner. If you're fortunate enough to be in a situation where you can have more of these expensive imaging techniques, probably magnetic resonance imaging would also be of aid in this evaluation of space-occupying lesions. So neoplasia evaluated still predominantly, I think, in most situations in the supratentorial part of the brain with CAT scanning, perhaps in the infratentorial areas or in the foramen magnum area by magnetic resonance imaging. Now, I want to also emphasize that from the clinical perspective, space-occupying lesions, if you will, broadly defined, would also include some sequelae of trauma, subdural hematomas, epidural hematomas, some sequelae of uncontrolled hypertension, thalamic or deep hemorrhages, putaminal hemorrhages, hemorrhages in the brain substance itself could be considered, in a sense, space-occupying lesions, because part of the evaluation is the effect of this collection of blood on the surrounding normal anatomy. Finally, post-traumatic, chronic post-traumatic sequelae, chronic subdurals in a patient who has a frequent trauma, perhaps a patient with a history of alcohol problems, someone with a history of falling from neurological disorder, post-trauma in certain sports. You may see chronic subdurals, and some of us may have that experience as sports physicians. That's another kind of space-occupying lesion.
This is a CT scan on a 53-year-old lady who has had increasing weakness in her left arm over the past several months. The CT scan and the axial projection without intravenous contrast injection reveals this abnormal region in the area of the basal ganglia on the right side. It is somewhat difficult to see, having both the low and high density components. The lesion can be made much more noticeable by injecting intravenous contrast, and the scan made after the intravenous injection shows the lesion as a very obvious bright signal. Here on the post-contrast scan, due to leakage of the contrast across the abnormal blood-brain barrier in the tumor, one cannot miss this primary brain tumor. This is typical of brain tumors in that intravenous contrast is often critical in detecting them and in defining their boundaries versus the adjacent edema. This is a 51-year-old lady who 2 days ago had the sudden onset of headache, paralysis of the left side of her body, and rapidly became unconscious. On the MR scan in the coronal projection, one can see an obvious lesion in the right temporal lobe. The MR nicely shows the anatomy. Using the advantage of the multiplanar scanning techniques, in the coronal plane is clearly within the temporal lobe. The tissue characteristic is very clearly a hematoma because of the unique brightness of the NMR signal, and the diagnosis of an intracerebral hemorrhage is quite obvious. What is interesting about this case is that the exact etiology of the hemorrhage can also be seen on another coronal scan. On this scan, which is approximately 2 centimeters anterior to the previous scan, at the front of the hemorrhage, you will note this irregular area of low signal or black appearance. This is indicative of flowing blood, in this particular case, in an aneurysm of the middle cerebral artery. So the MR has shown us the hemorrhage and the specific etiology of the hemorrhage and aneurysm, all in this completely non-invasive fashion without requiring the angiogram for the diagnosis in this particular case. This next patient is a 18-year-old male who had a diagnosis of a glioma, primary brain tumor, made approximately 1 year ago. On this coronal scan, we can see the explanation for the recurrence of the patient's symptoms, which is not the recurrence of the tumor. One can easily see this dark, low-signal collection of extracerebral fluid, a subdural hygroma, which has accumulated since surgery. The region of the tumor itself are these curvilinear regions of white or bright signal, and that is the residual of the X-ray therapy and not indicative of recurrent tumor. So that the MR is a nice way of following post-treatment cases to explain recurrence of symptoms, as well as evaluate the response to therapy.
Let's talk a little bit about blood flow.
Now, blood flow evaluation in the brain, I think, once again, from the clinician's perspective, still is not part of the day-to-day diagnostic armamentarium, but taking the patient with cerebrovascular disease, let's say that there's a couple of different situations in which we'd be interested in local blood flow. Most obvious one, I think, would be the patient who presents with a transient ischemic attack or reversible neurological defect, in whom you'd like to find out whether there is a total or partial occlusion of flow to a whole hemisphere because of extracranial occlusive disease at the bifurcation of the carotid artery. Now, that's not, so strictly speaking, brain scanning or brain imaging, but it's a very important part of neurological imaging. And I think evaluation of the patient with transient ischemic attacks or perhaps a stroke will be ultrasound evaluation, including both B-scan and Doppler evaluation of the carotid bifurcation. Now, in some medical centers, intravenously injected angiography done by digital subtraction angiographic techniques, so-called IV or intravenous DSA, is used as a screening procedure to evaluate the extracranial vessels. I want to spend just a moment discussing that. Our method of angiographic imaging, the tried and true method that we're used to, is to pass a catheter, of course, right up to the arterial region of interest and inject the iodinated contrast right into that area and produce a very high contrast, high quality shadow of that part of the vasculature. Now, the trouble with that is that in general, in the past, that's required bringing the patient in the hospital, gaining arterial access, usually through the femoral artery, and passing a catheter, sometimes through an atherosclerotic arterial system, with some attendant risks. Dissection of a vessel, hematoma, disruption of a plaque with subsequent embolization to the brain or elsewhere, and there are, of course, some risks in a procedure like that, although they're small. Now, the one way to get around that is to inject the dye intravenously and make a picture of the arterial structure when the dye gets there. The trouble with that, of course, is that the dye has been so diluted by the blood system by the time it gets there that there isn't too much iodine in that portion of the body, and therefore not too much contrast, not too much difference in X-ray attenuation between what's in the vessel and what's outside the vessel, obstructing the point of view. So the field of digital subtraction angiography was developed, and it goes something like this. You take an X-ray image of the a part of the body of interest before you do any injection of iodinated contrast. Then you inject a iodinated contrast substance intravenously and get another image when the small amount of iodine is in that area. Then by having each of the images in a digital form, you subtract, so to speak, one image from the other. You subtract the first image, which has everything but iodine, that's in the second image. And if you've subtracted them just right, and if you've superimposed those images exactly precisely, then you'll be left ideally with an image of just the distribution of iodine. And if we've done our subtraction adequately and done our registration or alignment of those images ideally, then we'll have a crisp view of the outline of the arteries, because that's the only place where iodine is. Now, that's in the ideal world. Often the patient's unable to sit stock still, there's respiratory motion, and so it's possible you may get some misalignment and blurring of the arteries. But in the hands, once again, depending on local expertise, there are radiologists who feel that intravenous DSA can be used as a screening test for extracranial occlusive disease, good enough perhaps to exclude or include further studies in a patient. In general, I think most of us are doing this with ultrasound examinations. Now that takes care of our discussion of blood flow imaging, so to speak, for extracranial carotid disease. Now, in terms of the substance of your question about brain blood flow imaging, there's a couple of approaches that we can talk about. In a very gross, kind of an overall global fashion, you can do blood flow imaging with a standard radionuclide brain scan, and that's used in some situations, for example, increasingly, as a way to identify brain death because of the lack of evidence of perfusion. There were situations in which we used 4-vessel angiography to identify evidence of brain death because of lack of perfusion through the 4 principal cerebral vessels, and in some areas that's being replaced in situations in which it's needed by standard radionuclide brain scanning. I want to mention a couple of approaches that are being used to attempt to quantitate regional cerebral perfusion that I have hopes are going to soon reach the clinical horizon. One that we talked about briefly is single photon emission computed tomography using radioactive xenon for regional brain scanning. We've seen some interesting preliminary evidence from radiologists at my institution that can be useful in a variety of disorders affecting cerebral perfusion. Secondly, much more precise quantitation of cerebral perfusion may be offered by positron emission tomography, utilizing a radioactive compound, positron compound, that follows blood flow, such as a radioactive or positron-labeled oxygen, labeled water, or other substances that will follow blood flow. So we have a couple shots at the cerebral blood flow scanning that I think we'll all be hearing more about.
Mm-hmm. It seems as though these days everyone thinks they have Alzheimer's disease. So what role do these imaging techniques play in degenerative or demyelinating diseases in the brain?
Well, first to answer about Alzheimer's, from my point of view, it's unclear right now exactly whether we're going to have a diagnostic aid. We have seen some examples have been shown by the nuclear medicine specialists at our institution of patterns of blood flow that they and the neurologists feel are representative or suggestive of Alzheimer's disease, decrements in blood flow to certain parts of the brain. I think the whole story isn't in on that. And give you a little more satisfactory answer on demyelinating disorders. The primary one, of course, multiple sclerosis, has always been a difficult diagnosis for the clinician. We tend to make it based on the clinical evaluation of a patient who has abnormalities in central nervous system function that's separated, so to speak, in space and time, different parts of the body at different times, showing central nervous system dysfunction. There are other ways of evaluating, making the diagnosis of multiple sclerosis that involve cerebral spinal fluid examinations, and there have been some findings on computed X-ray, computed tomography, suggestive, but not really specific and sensitive enough to hang your head on most of the time for the diagnosis. A lot of evidence is building up that magnetic resonance imaging may be an excellent way of identifying in most patients the presence of multiple sclerosis because of areas of increased brightness in certain types of pulse sequences used for magnetic resonance imaging. I think we can find some very good examples of patients with multiple sclerosis in whom you can make the diagnosis directly by imaging areas of demyelination in the central nervous system substance by magnetic resonance imaging.
Doctors Friedewald and Skorton will return next week to discuss diagnostic imaging of the cardiovascular system. For a printed transcript of Milestones in Medicine, send $3 to American Medical Video, Post Office Box 66588, Houston, Texas 77266. Please include the program title, content, and air date in your request. Allow 4 to 6 weeks for delivery. Milestones in Medicine is funded through a grant provided by Park Davis. Milestones in Medicine has been produced by American Medical Video, which is solely responsible for its content.
The pulmonary artery flotation catheter, its clinical applications and the controversies. Watch Physician's Journal Update next here on Lifetime Medical Television.
You know, when a friend of ours suggested I join AARP, the American Association of Retired Persons, I was surprised. I'm not retired, far from it. Then she told me 20 million people, both retired and working, belong to AARP. It's for anyone over 50. A $5 membership fee brings me free information on Social Security and pre-retirement planning, savings on travel and prescription drugs. I also get Modern Maturity, one of the most widely read magazines in America. Best of all, I'm part of one of the most vital voices in America, a voice government really listens to on important issues like pensions and Medicare. You can join AARP today by calling their toll-free number. They'll send you a complete information kit, including news about AARP's group health insurance. Once you've paid your $5, you'll receive a membership card. Use it to get discounts on hotel and car rentals. You'll also receive a monthly news bulletin. Don't wait. Call for your free information kit right now. You owe it to yourself to join the 20 million other AARP members who are getting the most out of life.
Come join the people of AARP.
Medical Minutes, 60 seconds of valuable information about no-fault insurance.
Well, under the proposed system, a doctor becomes automatically liable for all the bad outcomes associated with what are called compensable events. By compensable events, we mean events in which it typically turns out that a high percentage of bad outcomes are the result of negligence. In other words, we would pick a series of situations, for example, blood transfusion, in which we know many of the complications are the result of negligence, and we compensate all injured parties, those injured due to negligence, those injured just as part of the natural